So we'll talk about concepts and we'll talk about therapies. And we'll talk about differences between the right ventricle and, at least for what today we're going to call the wrong ventricle. The right ventricle has sort of been long forgotten, but there's increasing attention on the right ventricle, not only in the pulmonary community where it's been where there's been interest for a long time, but now in the cardiology community for reasons that I'm going to show you. I have no relationships to disclose with respect to this talk, which isn't quite the same thing as saying I have no relationships whatsoever. So you'll remember this is the basic physiology, 2 pumps in series, right? You got a right ventricle pumping into the pulmonary circulation, and you have a left ventricle pumping in the systemic circulation. So the old adages are no left ventricular failure without right ventricular success, and the left ventricle rarely fails alone because it backs up into the right ventricle. The right ventricle anatomically is a complicated structure. You can see over here, it's got an inflow tract, it's got an apex, it's got an infundibulum and a septum. That complicated geometry makes it a little difficult to evaluate right ventricular function, but we'll talk about just how to do that. And there are clear structural differences between the right and left ventricle as depicted on this pathological side. The left ventricle is spherical with thick walls, and the right ventricle is crescentic with thin walls. The right ventricle is also trabeculated, and this little thing here is the moderator band. That's the answer to the question on the echo. What is that thing in the right ventricle? Oh, it's just a moderator band. There really are the hemodynamic odd couple. So as you can see on the left, the right ventricle is afterload dependent. Stroke volume goes down as afterload decreases, and the left ventricle is not. Your blood pressure can vary within a fairly wide range without really decreasing your left ventricular output very much. And so that's because the right ventricle is a low pressure compliance system, and the left ventricle is a high pressure compliance system. For the purposes of this talk, we're going to talk about the right ventricle is sensitive to afterload. We're going to talk about all the things that can go wrong and increase right ventricular afterload. But the right ventricle and left ventricle are attached. This is actually an anatomical sample where you take out just the outside of both ventricles. And what you see here is that the fibers go from one side to the other. They wrap all the way around the heart, connecting the right ventricle. So in addition to this continuity between muscle fibers in the right and the left ventricle, the left ventricular septum contributes to the right ventricular free wall contraction, if you will, by pulling that right ventricle over and helping the left ventricular free wall go over. And in addition, they're both in the pericardium. So the pericardium modulates ventricular independence in some settings. That is when there's some pressure in the pericardium that connects the two, or when the heart dilates to pericardial constraint, then you have to think about the pericardium as well. So let's talk a little bit about hemodynamics. So this is the classic hemodynamic subsets after myocardial infarction. And so this is cardiac index here and pulmonary capillary wedge pressure. And if your wedge is low and your cardiac index is low, you're okay. And if your wedge is high and your cardiac index, if your wedge is low and your cardiac index is high, you're okay. Lots of survivors. And if your wedge is high and your cardiac index is low, it's not okay. That's cardiogenic shock. So this is what people used to think about when they thought about cardiogenic shock. This is Killip class 4. This one's Killip class 1. And notice there's no right ventricle in there at all. And that sort of has evolved to this thing. This is hemodynamic profiles from the shock trial. Again, similar data, but this is now left ventricular pressure over here and right ventricular pressure over here. If they're both low, it's either normal, or if they're really low, the patient's hypovolemic. If the left side pressures are high but the right side pressures are normal, you got left ventricular congestion. And if the right-sided pressures are high and the left side pressures are low, you have right ventricular congestion. But what you see is a lot of patients have biventricular congestion, and that's a challenge. So people, even in cardiogenic shock, have now begun to realize that you need to think about the right ventricle as well, because biventricular congestion is treated differently from left ventricular congestion. And in particular, as you're about to hear, it used to be that all you had were drugs that were kind of the same on the left and the right. But now you have support devices for the right ventricle, and that really has changed everything. So I'd like to change a little bit, and I'd like to be I'd like to look at it the way Guyton looked at it and go back to the stuff that I never really quite understood, and maybe I don't fully understand it now. But the idea is that, and any of you have heard Shelley Magder out in Canada, he does a brilliant job with this, and this is mostly stolen from his work. But in any case, what it says is that the cardiac output and the venous return have to be the same. They don't have to be the same beat to beat, but over time, it's got to get to the right side, and then it's got to get to the left side. But they fill in different ways. So this is a bathtub on the right side, and this bathtub is emptying into the right ventricle, and this is the pressure gradient for emptying into the right ventricle. So this is the Guyton curve. This is venous return over here, and as you can see, eventually you reach an equilibrium as the pressures go up. The Starling curve acts in, but you need to fill those pressures with the right ventricle, and you get to this equilibrium point, and then if the two curves are in the same place, it will go back to this equilibrium point at a certain cardiac output. But if you look at it a little closer here, this is mean systemic filling pressure. So that's the pressure in the veins. And for the blood to get from the veins into the right atrium, the mean systemic filling pressure has to be higher than right atrial pressure, right? Otherwise, the blood would go backwards. So you have to have a mean systemic pressure. So as this mean systemic filling pressure approaches the right atrium, eventually you get a point where flow is 0. So as the difference between the mean systemic pressure and the right atrial pressure gets bigger, then you have a greater flow into the right ventricle and greater cardiac output. What does this mean? This means that cardiac output, so the mean systemic filling pressure is what it is, right? It has to do with the fluid and the vascular tone and all that stuff. So in general, that doesn't always change very fast. So the cardiac output depends on lowering right atrial pressure at a given mean systemic filling pressure, or alternatively raising mean systemic filling pressure. And looked at that way, the function of the heart is to lower the right atrial pressure so that the right ventricle can fill. It's kind of the opposite way of looking at it from the way we usually do, but it, again, suggests the importance of thinking about right atrial pressures and right atrial functions. How do we do that? Well, in general, I'm not going to go through this slide in detail, but in general, the right ventricle isn't so easy to evaluate, but echocardiography, there are a number of ways to do it, sort of graphically depicted over here, and there's a really good article for those of you who are interested in it. This is the Journal of the American Society of Echocardiography. Lawrence Rudsky is another Canadian who spearlined these guidelines about evaluating right ventricular function. So you can look at fractional area change or tricuspid annular plane systolic excursion, which I had to read from the slide because I can't remember it. You know it as TAPSE, or myocardial performance index, which is over here. Probably because the right ventricle is a complicated structure, three-dimensional echocardiography to take into account the complexity of the structure is probably the best way to do it. Strain imaging, speckle tracking. The whole point of this slide is to suggest that if you really want to evaluate right ventricular function, this is pretty sophisticated. This is not something generally done by a 90-second bedside ultrasonographic evaluation. If you really need to know, you need to find the person. Not all echocardiographers. You need to find the person in this institution who understands it best to help you out. In addition, there's coupling between the right ventricle and the pulmonary artery, and we'll talk about that on the next couple of slides. But what it says is the cardiac output is maintained as the pulmonary artery pressure goes up, and then eventually the right ventricle begins to fail. And as the right ventricle, you can maintain coupling. So your right ventricle is failing, but your pulmonary artery pressure can go up, and then it fails, and the pulmonary artery pressure drops off. Thus saying that the pulmonary artery pressure by itself may not be what you need to know. You need to know the relationship between the pulmonary artery pressure and the right ventricular dysfunction. The other thing to think about is the interaction between the heart and the vasculature. Again, that's what coupling is, the interaction between the heart and the ventricle. This is the so-called Windkessel model. It's how your firefighters fight fire. They don't want spurts of water. They want a continuous stream of water. So you pump the blood from the stream into the pump, and it goes into this so-called Windkessel, wind being air, Kessel being container, and that pressure of air gives you a continuous stream. And that can be modeled as an electrical model here with a compliance and a resistance. On the left side, the pump is the heart, the resistance is downstream in the small vessels, and the compliance is in the elastic arteries. It's not the same on the right side of the heart. It turns out that on the right side of the heart, you have the same relationship, but in fact, the compliance and resistance are distributed throughout the circulation. So as opposed to having compliance it's not just the pulmonary artery, it's the whole circulation. And so when the right-sided circulation fills up, then its compliance, its stiffness goes up, its compliance goes down, and that increases the afterload of the right ventricle. And as we'll see, that can be important in therapy. So in the systemic circulation, most of the resistance is at the microvascular level, and most of the compliance is in the aorta. In the pulmonary circulation, as I said, they're distributed throughout the pulmonary tree. And that actually depends on the number of pulmonary vessels that are perfused. And so the right ventricular afterload depends on compliance as well as pulmonary vascular resistance in the small vessels. In addition, the right ventricular load is not just determined by pulmonary vascular resistance, and it's not just the effects of left atrial pressure. The right ventricle and the pulmonary artery are coupled. So I've used this term coupling a couple of times, and this is a great analogy from my friend Cliff Grayson. It's sort of analogous to gears on a bicycle. You want the gear to be right. If the gear is too low, you got to pedal and pedal and pedal to get everywhere. You don't like doing that. And if the gear is too high, it's really hard to move the pedals at all. So you kind of want to match the right gear to the right terrain. So that's what happens when it's coupled. And some of the coupling depends on wave reflection from the distal vessels. So the pressure wave goes out, it reflects off the distal vessels, and that reflects back into the right ventricle. So here's an example of right ventricular pulmonary artery coupling. And for the moment, we're going to talk about the ratio between these two numbers. This is EES is end systolic elastance. That's this line. That's a measure of contractility. And EA is arterial elastance, and that's a measure of afterload. So here we are normal. End systolic elastance over here is greater than end arterial elastance, and we have a decent stroke volume. As we begin to have failure, the end systolic, the afterload goes up, but it's compensated to some extent by an increase in contractility, and the right ventricle is still coupled. So the stroke volume is lower, but it generates pressure. And when you get out here, all of a sudden, the end systolic elastance can only increase so much. The afterload is much, much greater, and the right ventricular is uncoupled. And that's when the trouble happens, and that's when the right ventricle begins to fail. So right ventricular failure and right ventricular uncoupling are, to some extent, synonymous. And we'll talk a little bit about that. What are the implications for therapy? Well, there are implications for volume management, there are implications for contractility, and there are implications for support of the right ventricle. For the moment, we're going to talk about pharmacologic support. So in cardiogenic shock, fluid administration isn't really a good thing on the left side, right? I mean, it works a little bit in mild, but when you get severe, you're just filling up the lungs without much benefit. Now, the dogma was that you want to fill up the right side, but actually, it's usually not so good for the right side either. So the paper that's usually quoted about filling up the right side is this paper from Louis Dell'Italia, which has got to be 40 years old by now. And that paper is shown, and then what it actually shows is, if you go down here, that the cardiac index increases a little bit, and then afterwards it doesn't. Despite once the mean right atrial pressure starts to go up and the cardiac index doesn't go up, you might as well stop. You're just filling up the right ventricle, you're decreasing the compliance, and you're not increasing stroke volume because you're afterloading the right ventricle. So I'm not telling you not to load the right ventricle at all. I'm telling you not to load the right ventricle too much, and we'll talk a little bit about how to figure out whether you're on the too much side or you're on the just right side. So here we are. Resistance and compliance are distributed throughout the pulmonary tree. So right ventricular fluid overload can overdistend the pulmonary vessels and decrease compliance. You with me there? So how do you do that? Diuresis can improve compliance and can decrease right ventricular afterload. When you've got fluid and fluid and fluid, and you've got liters and liters in, that right ventricle doesn't like this, that right ventricle doesn't like it. And I have to tell you, hypotension and right ventricular failure rarely results from low right atrial pressure. Hypotension in traumatic shock results from low right atrial pressure, and you need to fill these people up in hemorrhagic shock. But in right-sided failure, that's not true. And the corollary is hypotension in response to diuretics doesn't happen because the right atrial pressure is low. It happens because furosemide is a vasodilator, and it lowers the blood pressure a little bit. What does that mean? That means that the response to hypotension and in the appropriate response to hypotension in response to furosemide is to vasoconstrict if you need to. It is not to stop the furosemide, and it is not to give another liter or two of fluid. That isn't going to work. That's just going to get you in more trouble. So in GI bleed, go ahead and give fluid. But in right ventricular failure, think long and hard before. If the fluid didn't work fast. You want to give 250 cc's and see what happens, that's okay. But after that, you really ought to think about whether fluid is the right thing to be given. How about contractility? Well, so we talked about right-sided, left-sided things. So if you don't know exactly where the problem in contractility is it on the left side and the right side, or both, it can be a little difficult to figure out what to do. So if you pick a vasoactive drug off the shelf and it works, well, okay. Well, Dr. Hollenberg, I picked drug A at dose B, and I did it, and next thing you know, the urine output doubled and the blood pressure doubled, et cetera, et cetera. However, if it's not working, you ought to think about whether you have a sense of what you should be doing. And you probably don't, at least I don't. So get some more information. How do you get more information? Well, echocardiography is a good thing to do. You want to, when the right ventricle gets overfilled, that ventricular septum goes over into the left side, and now the left side doesn't fill. So the position of the septum, and particularly the position of the septum in response to therapy, is a useful thing. When that septum starts going over into the left ventricle, it's time to go back the other way and try to reduce the volume. And also, hemodynamic assessment. It's a hemodynamic disease. Cardiogenic shock is a hemodynamic disease. How do you measure the pressure in the right ventricle? You put a catheter in that measures with a little pressure tip into the right ventricle, and you measure pressure. The wedge pressure may or may not help here. We'll talk about that in a little bit, but a hemodynamic assessment. And probably, rather than this big debate about whether an echo is good enough and whether a PA catheter is good enough, these patients are sick. Do it all. Do an echo, do a PA catheter. If you don't know what you're doing, get more information, please. Please, at least on me. When I'm your patient, get more information. All right. Another index that you'll see in the literature, and unfortunately the PC has ruined my lovely Mac slide, but in any case, is the pulmonary artery pulsatility index. What is this? This is basically an index. So pulmonary systolic minus pulmonary diastolic is the pulse pressure of the right ventricle, and the right atrial pressure is the filling pressure. So if your pulse pressure is high and your filling pressure is low, that's good. This number is high. If your pulse pressure is low stroke volume, and your filling pressure is high, that's bad. It's a low number. And here's a little bit of data out of Naveen Kapoor and Tufts that suggests that this pulmonary artery pulsatility index, in addition to right atrial pressure itself, is a pretty good way of detecting right ventricular failure. And there are some, you'll see if you look in the literature in cardiogenic shock, of the use of pulmonary artery pulsatility index to choose therapies. And then there's percutaneous right ventricular mechanical support. There's direct and indirect bypass, and I'm not going to say anything about that because you're going to hear plenty about that. But what I will say is that there are strategies for advanced cardiopulmonary support. So the idea is to try to figure out what your problem is in cardiogenic shock. If you've got a pulmonary problem, then you need to support the lungs. You need to use VV ECMO because none of the other support devices oxygenate while you're there. So you need VV ECMO to support the pulmonary oxygenation. If you have a cardiopulmonary problem, you want to ask whether it's a pulmonary plus the right ventricle. So if it is, then you need VA ECMO because you need a mechanical support. The right ventricle isn't pumping, so you need to pump the blood over to the left side for the right ventricle. Or biventricular, again, VA ECMO. So if your right side doesn't pump and you're not oxygenating, you need to support the right side with a mechanical support device, and you need to oxygenate with an oxygenator. If you've got a cardiac problem in the right ventricle, you want to support the right ventricle. If it's the left ventricle, you want to support the left ventricle. And it's both. Now you got a choice. Either maybe 2 assist devices on both sides or VA ECMO, and I'm thinking you're going to hear a lot more about that in the third talk today. So to conclude the physiology, shock is a hemodynamic disease. I would argue that understanding physiology and hemodynamic assessment is crucial both for diagnosis and to figure out management. And those eschewing hemodynamic assessment in the absence of evidence that measurement improves outcomes. If you're going to wait for the randomized controlled trial that proves that a monitoring technique in the absence not tied to a therapy improves outcomes, you look a little bit like this guy. So I'm not telling you how to do hemodynamic assessment. I'm just telling you it's a good idea. Thank you very much.